Hello and welcome to By the Book, a podcast series from ASCO. I'm Dr. Gerald Hsu, and on this show, we bring you compelling perspectives from the authors and editors of the ASCO Educational Book. I am honored to serve as the editor-in-chief of the ASCO Educational Book and delighted to be your guest host on the podcast today. In my day job, I'm a professor of clinical medicine at the University of California, San Francisco, where I also serve as director of the Hematology Oncology Fellowship Program. I also care for patients as a hematologist-oncologist at the San Francisco VA healthcare system. You may have already heard our exciting news. The EdBook has officially joined ASCO's family of journals. I'd like to invite you to be a part of this exciting new chapter by submitting your own articles and sharing your research with our growing global community. I'm thrilled to be joined today by Dr. Martin Dreyling, an internationally renowned lymphoma expert. Dr. Dreyling is a professor of medicine and head of the lymphoma program at the Department of Medicine 3 at LMU University Hospital in Munich, Germany. He will be sharing insights from his recently published article in the EdBook on the treatment landscape for mantle cell lymphoma, which he also discussed in an excellent education session at the annual meeting. Welcome, Dr. Dreyling.
Thank you.
I'm really looking forward to learning more from you about the current state and future of treatment in mantle cell lymphoma, and thought we could start with biological considerations that help us tailor treatment before moving on to first-line treatment, maintenance therapy, and treatment in the relapsed refractory setting. So one of the key points that you make in the EdBook article and session is that biological disease characteristics play a critical role in the prognosis and treatment outcomes in mantle cell lymphoma. And these include Ki67 proliferation, blastoid morphology, and TP53 mutation status. In your talk, you made a tantalizing point that there was forthcoming data that not all TP53 mutations are created equal. Could you elaborate?
I'm happy to have a closer look at the biological risk factors in mantle cell lymphoma. In fact, Ki67 and blastoid morphology is somewhat the same thing, looked at it from different angles. In that way, cytomorphology is what the pathology sees in routine diagnostics, whereas Ki67 is also a mandatory marker in the lymphoma world. Having said that, blastoid is more subjective, I'm afraid to say, whereas Ki67 is not perfect, but it's closer to objective measurement. Having said that, this one risk factor goes into the direction of cell proliferation, and therefore chemotherapy plays an important role. On the other hand, we have the risk factor of P53 alterations. And we all know P53 is a negative prognostic marker in all kinds of different tumors. I have to confess, I'm an oncologist as well. But the point is that this may be no more that relevant if you add some targeted approaches to chemotherapy. Now, in mantle cell lymphoma, the cornerstone of current treatment is really Bruton's tyrosine kinase inhibitors. And therefore, we investigated in the Triangle trial what is the impact on P53 alterations. And here it comes another important aspect in clinical routine. We have two methods to analyze P53 alterations. The one is sequencing, and with next generation sequencing, with whatever. This is, at least in US, clinical routine, meanwhile. It's not yet in Europe, I have to admit. And on the other hand, we have, let's say, the common people approach, which is immunohistochemistry. Immunohistochemistry is much less objective, but it's really targeting on the level of life, which is the protein level. And what we have analyzed, in fact, and these data have been presented at this year's EHA annual congress, is that if we take all patients with mantle cell lymphoma P53 mutations, half of them do show overexpression on the protein level, namely immunohistochemistry, and the other half doesn't. And then here it comes concerning the prognostic role in the chemotherapy world. And what clearly stood out was that P53 overexpression, so cases all with mutation, but on top of that overexpression, they have a much worse outcome than cases with P53 mutations only. And that makes perfect sense biological-wise, because we do know that mutated p53 is a dominant effect of the mutant allele, and therefore this blocks the p53 wild type, and therefore these cases not with nonsense mutations, so no p53 expression, but the ones with these mutated p53 allele, they have worse outcome. On the other hand, to be honest, this is the past in that way that chemotherapy alone is maybe no more the standard of care in the majority of patients with mantle cell lymphoma. And what about the role of p53 alterations in the world of BTKi containing regimens? And it's clear to say for both experimental arms, and we're talking about a total of more than 500 patients, to be honest, p53 has still some modest prognostic impact, but it's largely compensated by the addition of BTKi. Is that totally unexpected? No, because we have observed a similar impact in CLL, in fact, where exactly the same thing happened about 10 years ago, where the cases with p53 alterations, in these cases, it was a must-have to include BTKi. And I think now we know that this is exactly the same thing in mantle cell lymphoma with p53 alterations. And that also tells you that all of these risk factors also depend on the clinical setting. This is the difference between predictors and prognostic factors, which is essentially p53, the poor prognostic marker is partially overcome if you add BTKi. That's the bottom line.
So, Dr. Dreyling, it sounds like it may not matter exactly what the nature of the p53 alteration is, whether it's in the DNA binding domain or whether it's missense or whether it's a deletion, but that it results in overexpression of the protein. And that's primarily what's driving a more aggressive biology or resulting in adverse prognoses. Is that fair to say?
Absolutely. So the only point is, once you apply a targeted approach like BTK inhibitors, at least part of this negative prognostic impact is paralyzed. In that way, you only see a modest inferior outcome of cases with p53 alterations, and you can hardly see any difference between the cases mutated only or the cases with mutations and overexpression of p53.
Got it. So another example where some of our newer therapies, in this case, the BTK inhibitors, have really mitigated the impact of p53 alterations as an adverse prognostic feature.
Absolutely. And it's important to realize this is not the case for all targeted approaches, because we have already plenty of publications which suggest that the addition of lenalidomide plus chemotherapy does not overcome the poor prognostic impact of p53. So this is something specifically due to the addition or maybe targeting the B-cell receptor pathway.
Interesting. Moving on to considerations of induction therapy, another key takeaway point from your presentation was that we should be thinking about candidacy for aggressive induction therapy as opposed to transplant eligibility, given that there's a small percentage of patients that are really likely to benefit from transplant specifically. And for those patients who are not candidates for aggressive induction therapy, the addition of a BTK inhibitor to bendamustine rituximab is a consideration. And in what populations do you recommend it? And is it better than sequencing it with BR first and reserving BTK inhibitor for second line?
Let's start with the first part of your comment, which is there's only a small percentage of patients who really benefit from autologous transplant. And which patients are these? Well, I already commented on these two different risk factors. We covered p53. Now, the other one is high Ki67, and the cases with really extremely high Ki67, these are the ones which benefit of chemotherapy in general, and especially also of the addition of autologous transplant. Now, if you do that, it has to be always balanced against the toxicity of chemotherapy. One has to be honest. And therefore, for discussing the addition of autologous transplant, we did not have the common cutoff of above 30%, but above 50%. And the idea was We only want to really, apply this approach in the real aggressive cases to have a real benefit which overcomes the cost of additional toxicity. So what about the older patients? It's clear to say this is the majority of patients. In our prospective trials, we always say median age is 65. Well, if you go back to epidemiological data, you will see median age is 75. So clearly been said, even the fit 75-year-old chap, and I'm talking male because mantle cell lymphoma is mostly a male disease, he is not qualifying for autologous transplant. So what to do in these patients? And I already made the point that in principle, the more aggressive the mantle cell lymphoma, the more the benefit by adding chemotherapy. And in Europe, we're old-fashioned. Chemotherapy is still a backbone because we don't have registered non-chemo approaches so far. But it's important to say it also matters which kind of chemo you add. So in older patients, bendamustine is standard of care more or less. And Germany is a bendamustine country, but it's very, so we learned the lesson about bendamustine the hard way, which is there is some cumulative myelotoxicity. And therefore, in the beginning, the start with bendamustine is totally easy. Cycle 1, almost no hematotoxicity, but this counts up. And therefore, if you go for bendamustine in older patients in combination, for example, with a BTKi, we reduce the bendamustine dose from the beginning on to 70 milligrams per square meter. And if you're going for real older patients, which means 75 up to 80 or older, then we reduce the bendamustine dose to 50 milligrams. It's a very efficient drug in standard risk mantle cell lymphoma. If we are talking about the kind of disease with very high cell proliferation, let's make it 50 or 60%, then I think we have to consider this kind of disease more like an aggressive lymphoma, more like a large B-cell lymphoma. And we all know there, CHOP is standard of care, but CHOP is tolerated worse than bendamustine. But there's something like R-mini-CHOP, and that would be exactly my recommendation in patients, 75, 80 years old. Consider that one plus BTKi, because the disadvantage of bendamustine is in full dose, it's too myelotoxic, it's too immune suppressive, and therefore I think the BTKi can't play off their real potential. This is gut feeling, to be honest. This is expert opinion, lowest level of evidence, but that's my belief.
Is there a particular patient population for whom you recommend concurrent BTK inhibitor with bendamustine rituximab, or is sequencing okay?
First of all, which are the patients who qualify for chemotherapy only? Let's say BR with benda dose reduced. There's still, in my opinion, some patients, and these are the patients with very low risk profile. For example, the non-nodal leukemic disease, which is slowly progressing. And in these patients, BR still does do the job, fair to say. But I think it's a small niche between watch and wait and this patient population and really the optimal treatment, which is BR plus BTKi. And then about 2 years ago, there had been a poster at the ASH meeting where they analyzed patients retrospectively treated with BR followed by BTKi. And they compared these data to the randomized study, the ECHO study, which led to the registration of this combination. And of course, this is comparing apples with oranges. I mean, you can't compare prospective with retrospective. And in fact, in the randomized ECHO trial, this did already include, if you want so, a crossover, because all the patients in the BR arm, the vast majority did receive BTKi in relapse, either within the study, ACALA, or without the study by another BTKi. And we analyzed and found that around 80% of these patients did receive BTKi in first relapse. So this is pretty much what you can achieve in clinical routine. And what is the final result of that? If you have a look at the time to third line treatment, which therefore does include the first salvage treatment, so it does include the benefit, if you want so, to cross over from chemo to BTKi, you still see a significant PFS benefit. So from my personal opinion, I think this is really the vast minority of patients where you may consider starting with chemotherapy only. For the overall group, there's still some benefit of starting simultaneously with chemo plus BTKi.
Interesting. So it was really looking at the time to third line therapy that highlights this benefit.
Yep, exactly. And having said the good things, I also have to tell you the limitations of the ECHO study, because meanwhile, the overall curves, they split apart a little bit, but the difference is in the range, whatever, 5% or less, and it's not yet significant. So one has to be honest, this is in contrast into the results of the triangle trial in younger patients. And you could argue maybe in older patients, toxicity is more relevant. So therefore, this may play a role. And I'm talking of on-target toxicity, because all of these BTKi by nature, they lead to some kind of immune suppression. And the alternative explanation, independent of age, could be also that bendamustine is not the optimal combination partner. And that's based already, as discussed, on the high immune suppression. And I think it's a little bit of both of it.
Well, I'm glad you brought up toxicities here, because it seems as though no matter what a patient gets for their induction regimen, so if they're really fit and can tolerate aggressive therapy and getting the triangle regimen, or if they're older and frail and getting BR plus a BTK inhibitor, everyone seems to benefit from maintenance therapy. And with more treatments being included in the induction therapy, it seems like maintenance therapy is more than just rituximab. It may be rituximab plus the Bruton's tyrosine kinase inhibitor. And given the toxicities of BTK inhibitors, is there a way to doing some sort of risk-adapted or MRD-based maintenance therapy?
So first of all, you're absolutely right. It's a little bit strange. Now we have aggressive lymphoma where we do know maintenance does not play any major, if at all, role. And then we have follicular lymphoma, and in follicular typical indolent lymphoma, we have some benefit, but it only covers PFS, not overall survival. And then we have a disease like mantle cell lymphoma, which is more aggressive than follicular lymphoma. And still here have these strong data really supporting the benefit of maintenance. And that includes both. That includes rituximab maintenance, as shown by prior trials, but also the benefit of, let's say, BTKi maintenance, because I do believe, for example, in the triangle trial in younger patients, it's the 2-year maintenance which does the job, not the 57 days during induction. Now, having said that, question is how to optimize maintenance. In the triangle trial, in fact, we had a time fixed duration of maintenance, and that was 2 years. And my strong belief is that everything beyond 2 years mostly buys in more toxicity than it provides benefit for our patients. And on top of that, our patients, I'm afraid to say, but at a certain point, they are happy to get off the hook. They're happy no more seeing us on a regular basis for treatment. So this is why essentially all academic trials more or less go for a combined approach, but for a fixed duration approach. So in clinical routine so far, I would say, well, 2 years maintenance, full stop for everyone. But the field is moving, and you're right. And the question is, what about MRD? So spontaneously, you would say, well, for the patients, for example, who are MRD positive after induction, they definitely need rituximab maintenance. But for the ones who are MRD negative, they don't need a maintenance. Well, in real life, at least for anti-CD20 antibodies, it's just the opposite. So the patients who achieve an MRD negativity, a molecular remission after induction, they benefit especially from the maintenance. And why is that? Well, it's logical in some regards. They did receive rituximab during induction, and if rituximab with chemotherapy will not achieve a molecular remission, rituximab alone won't neither. So you always have to look closer at the data. What I, though, believe that in the future, we will double check this approach. And after 2 years, and has at least been shown for non-chemo regimens, that you check for MRD negativity after 2 years. And if patients are MRD negative, you can dare to stop the maintenance. In the ones which are still positive, you go on and still come out with great results. So for the non-chemo approaches, this is somewhat has been demonstrated in a couple of phase 2 studies. If you're starting with a chemo-based regimen, I think your induction is so effective that you probably can skip over or stop overall maintenance after 2 years.
Got it. So it sounds like we're still in the preliminary phases of potentially using MRD status after 2 years to guide decisions about continuing therapy or continuing some form of maintenance therapy. But this is not yet widely adopted. Is that fair to say?
Absolutely. So the commercial registration is unlimited treatment, but that also holds up, for example, for the ECHO regimen, which is the addition of BTKi plus BR. However, in real life, I would be very tolerant, very permissive if a patient comes up after 2 years and says, well, I have a little bit muscle pain, I have a little bit fatigue, I have these joint pains, to stop the BTKi.
Yeah, that sounds like a very common scenario. Well, let's move on to this next topic, treatment in the relapsed refractory setting. With the evolution in first-line treatment regimens, many patients who relapse today might be BTK inhibitor and venetoclax naive. At the moment, the preferred second-line regimen appears to be BTK inhibitor alone. And Dr. Toby Iyer in his presentation made the point that there is an absence of studies to demonstrate the benefit of combination therapies in this setting. Do you foresee this changing in the future?
This is a very important question. And unfortunately, the response or the answer is rather frustrating, because we have, in fact, 2 studies which exactly have tested or are testing that in a randomized fashion, which is the monotherapy BTKi only versus the combination with either venetoclax or second generation BCL2 agent. And what can we tell about the already published results of the first randomized study? Not surprisingly, the couplet is more efficient than the monotherapy. And I think this is clinically meaningful. Unfortunately, this is not registered. I think it's in the NCCN guidelines. So for our US colleagues, it's no problem to adapt it. And my bias would be, if you have a fixed duration BTKi in first line, then it's worthwhile to re-expose these patients again with BTKi 2-3 years later on. But then I would prefer to go right away for the combination. Having said that, this is somewhat has been already shown in CLL. There we do know if you have a fixed duration regimen, and this is why our CLL colleagues prefer that, and then patients relapse years after, they're still somewhat sensitive to the pre-exposed drugs. And unfortunately, the running trial, which is testing the second generation BTKi plus the second generation BCL2 antagonist, is also including only BTKi naive patients. So I fully agree, in 5 years from now, probably almost all patients in first relapse will be BTKi pre-exposed. So we definitely do need these data, but I'm not aware of any trial currently testing this scenario.
All right, so perhaps more to come. Is there anything in the future of Mantle therapy that you're particularly excited about?
You know, when we started this journey 30 years ago, I was told you can't perform a randomized study because there is no effective standard of care in mantle cell lymphoma. Well, obviously now the field has moved and we're really moving to the era of targeted approaches. So our colleagues from CLL are far ahead of us. But I strongly do believe the triplicate, like, for example, the bovine regimen, which is already established in the US as one standard of care, I think these triplicates will play a major role for the standard risk patients with mantle cell lymphoma. And in fact, once we have the randomized data, they may substitute really for chemotherapy. And this will be a blessing for our patients. Having said that, I think in high risk patients, this is not enough. Based on the long term outcome of bovine, after 3 years or so, still about 60% of patients are in remission, which is great, much better than chemotherapy. But just imagine you have a 50-year-old chap and you tell them, great, we will win against the disease, but only for 3 years. This is not a home run. And therefore, our hope, I really have to say, our hope is on immunotherapy, may it be bispecifics or CAR T cells. And my personal belief is that an intelligent combination, BTKi plus something, and here I'm not talking chemotherapy like in large B-cell lymphoma, I'm more talking targeted treatment, some kind of BTKi, some kind of degrader, whatever. These combined approaches still rather well tolerable. They have the potential to overcome the disease also in high-risk disease. Of course, this has to be proven in prospective trials, and I'm happy to say that the majority of the study results we talked about are, in fact, independent academic studies. And I think this is an important role for academic studies. As a clinician, you ask different questions. And working together with a pharmaceutical company, I think this is a win-win situation to really improve outcome in the interest of all of our patients.
Well, it's really exciting to see all the tools coming online to help patients with mantle cell lymphoma. And amazing to think that 30 years ago, it was thought that you couldn't do a randomized trial because there were no standard arms. So how far we've come.
Yep.
Well, Dr. Dreyling, thank you so much for sharing your fantastic insights with us today on the podcast.
Well, thank you for having me.
And thank you to our listeners for your time today. You will find a link to Dr. Dreyling's EdBook article in the transcript of this episode, as well as a link to his education session. Before we go, I want to invite you, our listeners, to be a part of our exciting next chapter for the journal. Please consider submitting your own articles and sharing your research with our growing global community. ASCO Publications Author Center for non-meeting associated content is where to go to find the new article types that we will be publishing within the educational book. These include a State of the Science article type, Clinical Connections and Innovations in Oncology Education. Please join us again next month on By the Book for more insights on key advances and innovations that are shaping modern oncology. Before we go, if you enjoyed this episode, please take a moment to rate, review, and subscribe to the podcast on your favorite platform. Thanks, Dr. Dreyling.
Thank you.
The purpose of this podcast is to educate and to inform. This is not a substitute for professional medical care and is not intended for use in the diagnosis or treatment of individual conditions. Guests on this podcast express their own opinions, experience, and conclusions. Guest statements on the podcast do not express the opinions of ASCO. The mention of any product, service, organization, activity, or therapy should not be construed as an ASCO endorsement.